Okay, so next we are going to record carcinoma prostate. A man with BPH, poor urine stream, low back pain. 65-year-old man referred by GP with increasing poor urinary system, urinary stream and nocturia. He had a stroke last year and has atrial fibrillation and takes warfarin. Undergoing examination for prostatic size assessment. Diarrhea was done and a film round prostate was felt. What's your diagnosis? This is BPH, benign prostatic hyperplasia. What is the cause of prostate enlargement for this patient? Androgen that causes hormone stimulation of gland and stromal growth. So it's androgens like testosterone which stimulates the stroma. So this is the real culprit. What would be your examination, per rectal examination finding in case of carcinoma? So per rectal findings of SCA prostate are hard, nodular, fixation with the rectal wall, obliterated median circle. So now you can compare. Now you can compare this DRE was done and film round prostate was felt. And here hard nodular fixation with the rectal wall, obliteration of the middle. So when it's nodular, it's CA. When it's film smooth, it's BPH. Okay, mobile. It can move, you can move it, but here it's fixed to the rectal wall. So roughly we can say that these are the differentiating points. Okay, now how to take prostate biopsy? Transrectal ultrasound guided from. So you can take it transrectal ultrasound guided from mid-lobe parasagittal plane at the apex, the midgland, and the base bilaterally. So usually we take multiple biopsies. Transrectal ultrasound biopsy. Why will you take multiple biopsies? At least 10 biopsy samples. Prostate cancer can be focal, so it's important to take samples from different sites. There is often only a scant amount of tissue available for histological examination in needle biopsies. Malignant glands may be admixed with the numerous benign glands. Moreover, the histological findings pointing to malignancy may be subtle, leading to underdiagnosis. There are also benign mimickers of cancer that can lead to misdiagnosis of cancer. So you have to take multiple biopsies. These are the reasons. How to differentiate between rectum and prostate cells in a needle biopsy? Using immunohistochemical markers alpha methyl acyl coenzyme A racemase AMACR alpha methyl acyl coenzyme A racemase. So this on immunohistochemistry you will find this CA in rectal. This will be in prostate, this will be in rectal cells. Immunohistochemistry for P63, high molecular weight cytokeratin should be negative with the rectal tissues as the rectal glands lack basal cells. Immunohistochemical for racemase is not useful as it is 97% positive in prostate CA, but also in positive in some benign prostate lesion and may positive in 70% of rectal cancer. The biopsy describes several cores of tissue, some showing a high grade of prostatic neoplasia. There is a mixture of non-prostatic rectal glandular tissue. How to tell what test can be applied to confirm non-prostatic elements? So, immunohistochemistry for colon antigen will be positive and PSA will be negative, and CA will be positive for colonic and rectal tissues. So you can differentiate on this basis. What are the gene mutations involved in pathogenesis of prostate cancer? The most common acquired genetic lesion in prostate carcinoma are TP or SS2 ETS fusion genes, and mutation or deletions that activate the PI3K or AKT signaling pathway. So you have to remember this. The gene fusion between transmembrane protease serine 2, TMPRSS2, and E26 ETS transcription factors are present in all 50% of patients with prostate cancer. His symptoms responded to treatment, but after 6 months, PCA 20 nanogram. His midstream urine negative. What is the significance of PSA in this case? So, raised possibility of prostatic neoplasia. His symptoms responded to treatment, but after 6 months, PSA is raised. Okay. Patient went to radical prostatectomy. PSA is 7. 3 months later. How can you judge the success of radical prostatectomy? Fall in the level of PSA below detectable levels within 4 to 6 weeks. High PSA of prostatectomy recurrence should be considered. So, why PSA is not reliable? PSA is organ specific but not cancer specific. This is such a good statement. Although serum levels of PSA are elevated to a lesser extent in BPH than in prostatic carcinomas, there is considerable overlap. Other factors such as prostatitis, infarction of nodular hyperplasia, instrumentation of the prostate, ejaculation, DRE can also increase PSA levels. So PSA is not specific. What is the grading system? Gleason score grade prostate tumors from 2 to 10, 10 being the most abnormal and therefore the most likely to spread. The pathologist allocates a number from 1 to 5 for the most common histological pattern in the specimen, then does the same for the second most common pattern. The sum of these two numbers will be Gleason score. Now we will do the Gleason score. So most common is 1 to 5 and then second most common. Okay. So what does Gleason score 3 plus 4 is equal to 7 mean? 3 is primary grade or dominant pattern of tumor in the biopsy greater than 50% of the total pattern, and 4 is secondary grade next most frequent pattern of tumor in the biopsy less than 50% but at least 5% of the pattern. So 7 is the combined Gleason score. Okay. So there is difference in prognosis of prostate cancer between the Gleason score 3 plus 4 is equal to 7 and 4 plus 3 is equal to 7, because the most common will be 4 and the most common here will be 3. So there is a difference between these two. The first score has a better prognosis because the most common pattern in the biopsy pattern is pattern 3. Okay. Nowadays we have tertiary grade, which is a small component of third pattern, generally more aggressive pattern in the biopsy. If 3 patterns are seen, the first number of the score would be primary grade and the second number of the pattern would be highest grade. For example, if in the biopsy 3 pattern, primary grade 2, secondary grade 3 and tertiary grade 4, the result of the Gleason will be this. 2 plus 4 is equal to 6. So you will ignore this secondary. And also you have to look for this as well. So small uniform grade 1 differentiated. Grade 2 more stroma between glands, distinctly infiltrative antigens, irregular masses and neoplastic glands, only occasional gland formation. So these are poorly differentiated on this side. If a patient with prostate cancer develops back pain and CT showed increased density in the lumbar spine, what's your diagnosis? Bone metastasis. One test to exclude bone metastasis, alkaline phosphatase. You can also do PET scan as well. PET scan. Okay. What kind of metastasis? Osteosclerotic 80%, osteolytic 20%. What is sclerotic metastasis? To increase bone deposition, to increase osteoblastic activity. Radical prostatectomy was done. Now postoperative developed fever, dusky red urine. Why? Or postoperative day 1, patient is confused and has raised white cell count. Why? This is because of UTI. This is because of UTI. Colony forming unit in UTI. Minimum amount of bacteria required to cause UTI. UTI is typically caused by a single organism that is present in high concentration, usually greater than or equal to 10 to the power 5 coliform unit per ml. Which of the blood components will rise? WBC neutrophil. Most common organism, E. coli. 1 year after surgery, PSA is 3 nanogram per ml. Why does it indicate recurrence? PSA is only secreted by prostatic tissues. If all prostatic tissues was removed, for example, you have done radical prostatectomy, PSA should not be present. So after surgery, this level indicates recurrence. Normally, this level is normal, but after radical prostatectomy, this should be 0. What is the rationale in treating prostate cancer by bilateral orchidectomy? So, so we know that androgens or testosterone is produced by testes. So, bilateral orchidectomy is called will give you androgen deprivation. The growth and survival of the prostate cancer cell depends on the androgens, which bind to the androgen receptors AR and induce the expression of pro-growth and pro-survival genes. What are the cell-producing testosterone? Okay, so testosterone is produced by the interstitial cells of Leydig cells. So let's suppose these are testes, these are seminiferous tubules, in which we have the germ cells. So in this interstitial space we have the Leydig cells. These Leydig cells will produce testosterone. Inside the germ cells, there are like germ cells inside the spermatozoa. Along with this, there are other cells called Sartori cells. They nourish the germ cells. So this was the prostate cancer video.